about how we manage thoracic surgery patients. So a few disclaimers. So I think the most important things on watch really just dependent upon the specific patient. So there's going to be exceptions to everything, that I tell you guys about today. So we just have to take that into context. I have no financial disclosures and sense of quantity this from. I think it's helpful if you're managing a thoracic surgery patient. When I say thoracic surgery patient, I'm speaking more to patients who have speaking more about patients who are undergoing who have undergone a lung resection. We obviously operate on patients outside of the lungs. You may see some of our patients who are who have undergone a hiatal hernia repair. That's probably the most common non-lung operation we do here. But this is really just going to be focused on patients we've operated on for the lungs. So I think it's helpful if you're going to take care of patients who have lung resection or lung surgery to understand the general physiology behind how we breathe. Okay, and so anybody tell me a little bit about what they think, the process of breathing, how we breathe physiologically, how that happens. I'll try to make this a little bit interactive.
O2 in, carbon dioxide out, please.
Okay, all right, yeah, that's great. So, that's a great way to think about it. So, there's two main functions, right, in terms of breathing: we have oxygenation and we have ventilation, and those are two separate things, right? So, oxygenation has to do with when you inspire oxygen, so your FiO2, when you inspire air or nasal cannula, or if you're intubated and a specific fraction of inspired oxygen, that oxygen has to go in through your airways, has to reach the lungs, has to reach the alveoli, and then there's gas exchange between the alveoli and the capillaries within the lungs, and then that oxygenates the blood, and that helps with aerobic metabolism, right? That's how we utilize ATP, right? Krebs cycle, a lot of stuff from back in biochem. So that's how we live, right? Our mitochondria need the oxygen to function. The other function of the lungs and respiration is ventilation, right? That's getting rid of carbon dioxide. So that's really, as a function of metabolism, we create carbon dioxide when we're using glucose. So going back to probably seventh grade biology, right? When you talk about glucose and that whole process, right? It creates water and carbon dioxide. So you got to get rid of that carbon dioxide, because if that carbon dioxide builds up, what happens when our carbon dioxide builds up? There's someone that volunteer.
Suppresses your drive to breathe.
Yeah, it suppresses your drive to breathe. And what else happens when patients are really hypercapnic, right? That's the term we use to describe when patients' blood CO2 is really, really high. What else happens to them?
Acidotic.
They become acidotic, yes, right? So then your pH, right, of your blood decreases, right? You become acidotic, and then usually the first sign of that is going to be somnolence, right? People are sleepy, right? And so you can ventilate, you can oxygenate through a pinhole, you can't ventilate through a pinhole. So patients who aren't ventilating, they become sleepy, and then you may not pick up on it because of the fact that the O2 sat's 99, 100%. Until they become so sleepy, they stop breathing, and then their oxygenation goes down, and then they cope behind. So important to recognize there's two functions of breathing. So in terms of the physiology behind the mechanics of how we breathe, right? So what happens is you can think of the lungs as sitting within the pleural cavity, and the pleural cavity is a negative pressure space. And what I mean by that is you measure the actual pressure within the pleural cavity, there's a little bit of fluid, and when we breathe, our chest expands, our diaphragm flattens out, and so we actually stretch that space. And so as we stretch that space, we suck air into the lungs. So the lungs are basically like a bellow. I don't even know we use bellows anymore, but those big old bellows, they suck air in. And that's how we breathe, right? We suck air in, and that's a negative pressure way of breathing. And so you think about the old iron lungs for polio. That's sort of how physiologically we breathe, right? We expand our chest, and that sucks air in. Positive pressure ventilation is different, right? So we put somebody on CPAP, we intubate them, we're forcing air in, and so that's why the physiology is a little bit different for how we breathe while we're on a ventilator, while we're on a CPAP, or BiPAP. Okay. This is basically saying a very similar thing. Essentially, so the diaphragm flattens out, the ribs, there's sort of bucket handle description if you read textbooks about how as you breathe, the ribs move, and that increases the volume in the chest cavity, and that essentially we suck the lung open, we suck air in, that's how we breathe. Same sort of thing. And so there's a natural tendency for lungs to, if you put a hole in the chest and you open up the lung, have you ever seen lungs, outside of the body, but they're kind of small and not very impressive. When they're in the body, they're really expanded. They're like a balloon, basically. I put this picture up to remind us. So the way I think about that negative pleural space is, if you think about like a cup of iced tea on a hot summer day on a glass table, right? And so if you try to pull up on that cup, there's a little bit of resistance, right? And there's that negative pressure between the cup and the glass table. Once you break that interface, the cup comes up, and there's no, you're not pulling up the table anymore, and there's no resistance. But while there's that negative pressure and that suction, that vacuum, there's that resistance floating up. So I think of the lungs in a very similar way, right? You put a hole in the chest wall, you've gotten rid of that negative pressure, and all of a sudden the lungs are decoupled from the chest wall. So that's why pneumothoraces and pleural fluids can really affect our breathing, is because they, especially pneumothorax, that can really decouple that negative pressure. All right. So moving on to sort of the general preoperative workup. You guys don't need to know all this stuff, but just generally what we're thinking about when we're evaluating patients. Obviously, how fit does this patient look? Are they going to tolerate a surgery? You look at their past medical history and their meds. You look at the labs, look at the imaging. Cardiac assessment is very important in my opinion. The heart and lungs are linked, right? And so when a lot of times people have really bad pulmonary physiology, that can translate into effects on the heart. Do you guys know which side of the heart, if you have bad lung physiology, is going to be affected more? Which side of the heart pumps blood? So typically it's actually the right side. Yeah. So the right side of the heart pumps blood to the lungs, right? The left side of the heart pumps blood to the rest of the body. And so the way I describe that relationship is the left side is very strong, right? You think about your entire life, your heart, the left side is pumping blood throughout the entire body, and it has to pump blood all the way throughout, and has to get the blood all the way back in, via venous drainage and lymphatics and whatnot. But the left side is used to pumping blood really hard and against a lot of resistance. For trivia, anybody know what animal has the highest blood pressure? Think about what I just told you about, pumping blood all the way up and back down.
Oh, a giraffe.
Right? It has to get blood all the way up to its brain, right? And so it has very, very high, very high blood pressure as well. So, but so the left side is conditioned to handle that. And so over time, when people are in hypertension, the left side becomes hypertrophied, right? You work out a lot, you work out against resistance, the muscle becomes thicker. And over time, that can lead to issues with the heart getting blood perfusion to the inside of it. But the left side can handle a little bit of increased resistance. The right side's different. Right? The right side is pumping blood from here to here and back. There's so many capillaries in the lungs that the resistance is very, very low. There's just tons and tons of capillaries. So the right side is not used to a lot of resistance. So when patients have issues with high blood pressure in the lungs, we call pulmonary hypertension, that can be a very dangerous thing. And what ends up happening is the right side is not conditioned to handle that increased pressure. And you can have right ventricular distension. So the right ventricle kind of stretches a bit. I don't know if you guys remember from physiology, right? The Starling curve, right? So if you want to increase the strength of a muscle and how strongly it contracts, you stretch the muscle, right? It's like a spring, and you stretch it and it contracts, and it has more force. Keep stretching to a certain point though, and eventually it drops off. It gets so distended that it's no longer able to really contract well. And so that's when we start to see right ventricular failure, and that's very, very dangerous. And so, one of the first things we think of in management of that is you want to basically decrease the pulmonary hypertension. So we give oxygen. And what that does is that causes pulmonary vasodilation, and that helps the right heart handle that increased pressure. Hopefully, we're not operating on too many patients with pulmonary hypertension here, but that's something to think about. Okay. And then pulmonary, obviously, if we're taking up part of the lung, you got to know how good the rest of the lung is. And so we look at pulmonary function tests. We look at something called the FEV1, forced expiratory volume over 1 second, and then the DLCO, which is a measurement of the diffusion of gas across those membranes. So those are the two big things we look at preoperatively. I know you guys aren't involved routinely in this, but I think it's helpful for you guys to get a sense as to what we're thinking about when we make the decision to operate, so you guys don't think we're all crazy cowboys operating on inappropriate patients. All right, so intraoperatively. So when we're in the operating room, I think of being in the operating room and in this perioperative period almost like being in the ICU, right? If you guys don't remember from your ICU rotations, or if you're in the ICU now, it's by systems, right? So when they're in the OR, when they're sick, when we're going through surgery, neurologically, what are we doing for them? Are we giving them pain medication? Are they on sedation? Are they paralyzed and asleep? Cardiac, we're keeping a close eye on their heart rate, their blood pressure throughout the operation. Obviously, we don't want them too hypertensive or hypotensive or tachycardic or bradycardic. So all those things are managed, by the anesthesiologist. Pulmonary. So we'll talk about the way we ventilate these patients, which is a little bit different than kind of your general surgery patients. GI, sometimes we place an NG tube. They're obviously NPO the night before the operation because of risk of aspiration. GU, sometimes they get a Foley, sometimes not. We just keep an eye on the urine output. They're usually on some fluids. Endocrine, they'll sometimes check, finger sticks in the OR. And then I usually give subcu heparin right before the operation, like 5,000 typically. And then they usually get a dose of preoperative antibiotics. If the case is really long, typically we redose the antibiotics because the antibiotics have to have a half-life. So this is how we actually do the operations in terms of the ventilation. So you have two lungs, obviously, and so most people do have two lungs, and so you need to find some way when you're operating to deflate one of the lungs. Okay, to do that, we have to use single lung ventilation, and there's a few different ways that we can do that. The most common way is typically with something called a double lumen endotracheal tube, and so it's this thing here, and so typically this gets placed in the operating room by the anesthesiologist, and we're usually there to assist in the positioning of it. Okay, these typically will go on either the right side or the left side, and typically it's the left side. Can anybody tell me why they think it would be the left side?
Because the left side has just the two lungs.
Yeah, so it's sort of, so you're getting sort of at it. So it's actually easier to place things down the right side. Okay, the right side, I don't know how well you can see it here, but basically the right side comes off more straight from the trachea. The left side angulates a bit more. So it's actually harder when people aspirate things. Either they're what they ate for dinner the night before, or I don't know. We had one guy with a shrimp tail in his airways. It's typically in the right side, and it's typically in the right lower lobe. And the reason for that is if you look at the airway, it's a much straighter shot down to the right lower lobe over here. The reason we place it on the left, though, is because of this. This is the right upper lobe bronchus. Okay, I don't know if I can just show it on the mouse or not. Anyways, this is the right upper lobe bronchus. And so when you want to ventilate a single lung, you want to make sure that you're only ventilating that lung. And not a part of the lung. Let me make sure that that's the entire lung, not a part of the lung. So the issue is if you place this on this side, sometimes the balloon for the bronchial lumen can block the airway for the upper lobe. So that's the reason why these are typically placed on the left side. So this, I probably should explain a little bit about the double lumen endotracheal tube. So basically, when I say double lumen, it has two channels, right? There's a channel that ends in the trachea, and there's a channel that ends in the bronchus. Okay. And then there's two different balloons. There's a tracheal balloon and there's a bronchial balloon. So when this is placed correctly, we have access to ventilate just the left side, right? So if we have this inflated and we don't ventilate this tracheal side, air is only going to go down this side and it can't come back out because you have a cuff blocking it, okay? If we want to ventilate the right side, same thing. We have both cuffs up, air goes down this way, we don't ventilate this side, air can't go onto the left side. So we can work on the left side, or we can work, if we want to do the right side, we ventilate the left side, and then we deflate the right side. Does that make sense? Okay. All right. So that's how we get these operations done. The other option is you can place a bronchial blocker. So it's basically a little balloon. It's not as commonly done, but in certain cases we will. So we'll have the anesthesiologist place the regular single lumen endotracheal tube, and then we'll guide a bronchial balloon. It's basically like a Fogarty balloon, and you can place the balloon to block a particular airway that you don't want ventilated. Okay, everybody follow me so far? So what do we do when we're actually in the operating room? So most of the stuff we're going to do is either be VATS, video assisted thoracoscopic surgery, or robotic, which is basically the same thing, but just using the robot. And so typically we get into the chest, we get into the pleural space, the lung is collapsed, hopefully, and we're able to get in and work in that space around the lung within the chest cavity. And depending upon what we're doing, that'll determine whether to do robotically or VATS, the number of incisions and how big our incisions are, et cetera, et cetera. So this is just schematically what it looks like. We have our patients on their side that we're operating on up. So this would be, we're doing a right-sided operation here. The patient's we call left lateral decubitus position. And so we're in the chest. And this is just a picture of some random operation. But this is actually what it looks like in the chest, right? So you have your pleural space. Though you can kind of see the ribs over there, and that's the lung that's being divided by a stapler. We use staplers to cut the lung. The way I describe the lungs are they're like sponge that have saran wrap around them. So if you just cut directly into the lung, air is going to leak out of the lung, go into that pleural space. Remember we talked about that analogy with the ice tea on the glass table. You lose that, you decouple that negative pressure in the chest space, and then all of a sudden the lung collapses. And then that's when people have the pneumothorax. Okay, that's that. And then what are the sorts of operations we do in the lungs? So, I don't know if you guys can see, but so a lot of times we're operating for cancer, or we're trying to get a diagnosis as to what's going on with a nodule, or maybe they've got really bad lungs and we're just trying to do a lung biopsy. In those cases, we'll take out a part of the lung, right? So we use those staplers like I talked about to divide the lung. And so for a cancer operation, there's lots of different types of resections we can do. We can do a wedge, where basically we just take the tumor and maybe some surrounding lung parenchyma around it. Basically, just find the nodule, pull up on it, fire a stapler underneath, and that's a wedge. Okay. You can take out the entire lung, right? So that's what we call a pneumonectomy, where we take out the entire lung. Honestly, I don't know how many pneumonectomies we're going to be doing here, but probably not a ton because it's a little bit higher risk. But that is an operation that we do sometimes. Okay. You can do a lobectomy where you take out an entire lobe. Okay. And when we do that, we take, the right side's got 3 lobes, the left side's got 2, like you mentioned. When we do a lobectomy or a segmental resection, we need to divide the vessels as well as the airway separately. And then also, if there's any connection between the different lobes or segments, we need to divide that as well with staplers. So those are the different lung resections we do. And that's usually for lung cancer. I'll get to other times we do a wedge, but typically these are for either diagnosing cancer or treating a cancer. Okay. This is somebody who probably had a pretty bad pneumonia that developed into something called a parapneumonic effusion. So what happens is, you think about when you sprain your ankle, your leg swells up, right? Same kind of thing can happen with an infection. So you get fluid that leaks around the lung in the pleural space, and that's what we call a parapneumonic effusion. If it sits there for long enough, you get fibrin that builds up and you get loculations within the fluid. And this is actually not that bad. I don't get this picture now. But that's the lung under there. Those are some adhesions and stuff, to the chest wall. What we need to do is something called a decortication, where basically we go in, we clean up all this stuff, and then what happens is there's a rind that forms on the lung. And the rind is almost like an orange peel where it will constrict the lung. And you have to peel that off the lung so that the lung can expand. It's no longer constricted by that fibrin. And depending upon how long it's been sitting there for, it can be pretty rough. It's funny, I made these slides 2 days ago or yesterday during the day, and then I took somebody to the operating room. I had like way more impressive pictures than this. But these were again pilfered from the inside. It was easier. Sometimes we operate on people because they have a pneumothorax, right? So a lot of times it's either a tall, skinny young man. That's kind of the classic spontaneous, we call spontaneous pneumothorax, meaning they didn't have anything done. They were just, hanging out, and all of a sudden sharp pain. They get, shortness of breath. They get an X-ray, and the lung is collapsed. Why is it in tall, skinny men? A lot of times there's some links with Marfan syndrome. And so we think maybe it has to do with their connective tissue just a little bit different. So they're more prone to having the lung be abnormal and pop and cause pneumothorax. Some people think that it has to do with like the differential growth rate, like their body grows faster than the lungs do, and that's why it stretches the lung in a weird way. Who knows? But in any case, that's one population of patients that we see spontaneous pneumothorax in. The other population is older people with bad emphysema, bad COPD, and their lungs are just crappy and stretched out, and then they cough a funny way. Actually, I think it was here. Yeah, I had a guy. I don't know if any guys took care of my guy, my older guy with dementia who was on BiPAP and then at home, and then had a spontaneous pneumo, and they operated on him. Anybody guys take care of him? No. Super nice guy. His wife was a former nurse and was like totally on top of it. Anyways, but that's another. He actually, interestingly, didn't have a lot of lung disease, but he had a little bit of a funny area of lung that I resected. But older COPD patients with bad emphysema, that's another kind of classic at-risk patient for having these. So what we do is we go in there, we find any areas of disease. Obviously, if there's a hole in the lung, we'll cut that area of the lung out and we'll use the staplers. And the other thing you want to do is you want to get rid of any space, right? Remember we talked about the fact that you rely on that negative pressure. Sometimes you can't just rely only on the negative pressure. You kind of have to get the lung to scar up against the chest wall. And so that's when we do something called the pleurodesis. And that basically just means you're kind of sealing the lining of the lung, which is the visceral pleura, against the parietal pleura, which is the lining of the chest wall. And so you get the lung to expand. There's a few different ways you can do it. In an older person with bad COPD, we'll use talc, and we'll just insufflate a bunch of talc into the chest, and that causes an inflammatory reaction. The lung sticks up against the chest wall. You leave some tubes. You wait. I usually wait 48 plus hours on suction, and you just wait for the lung to scar up against the chest wall, and that helps prevent this from happening again. The other option, a younger guy, the younger guy with spontaneous pneumo, I'll typically do a mechanical pleurodesis, meaning I'll rough up the inside lining of the chest wall, maybe and sometimes peel the pleura off the chest wall and do what's called a pleurectomy, and that really can get the lung to stick up against the chest wall. It's just so inflamed once you do that, and that helps prevent it from happening again. Because that's really what you're trying to prevent, is having them come in. And even if they do pop the lung a little bit more, again at some point, the lung is so stuck up against the chest wall that it'll be a very small pneumothorax, loculated pneumothorax that you don't need to. It's not usually life-threatening. Does that make sense? Any questions? Okay. I'm sure you guys are probably all taking care of one or two varieties of these patients. All right. All right. So peri and postoperative care. So again, in an ICU fashion. So pain control is really, really, really important, in my opinion, for these post-op patients. You think about where your nerves run and how they run. So your nerves come from your spine, right, and they go around to the front. So the highest concentration of nerves is actually along the back and towards the front. They run between the ribs. We have to go between the ribs to get into the chest, so it can be very painful if those nerves are injured. And so I usually warn patients that I'm operating on electively that is, a possibility that you have a lot of pain. Especially for a thoracotomy and open incision, it's actually more pain, can be more painful than a median sternotomy, open heart surgery. The way I kind of think about it is, people aren't ticklish here, right? People kind of pound on their chest and they're totally fine. People are sensitive on the sides, right? You kind of like, if you knuckle somebody in the ribs, it's uncomfortable. So I tell patients it's going to hurt. So we really want good analgesic pain, analgesic control. So multimodal is always a good thing. So I personally like using a mix of some sort of NSAID, so either Toradol, ibuprofen, Tylenol, either oral or IV, and then some narcotic pain medications, sort of how I manage these patients. And I told them that, post-operatively, I would recommend if there's no contraindication, taking the ibuprofen, taking the Tylenol around the clock, using the oxycodone as needed. If you don't need the oxycodone, taper yourself off of that, and then, taper yourself off of one of them, one of the other over-the-counter meds, and then taper yourself off. So the majority of patients are off narcotics by the time I see them, which is usually about 2 weeks post-op. All right. But the pain control is very important because it ties in with pulmonary. I'll go over that in a second. Cardiac, if they're on a beta blocker, I'll usually do them at least initially post-op on an IV form of Lopressor. So I usually do 5, the Q4, Q6 hour standing with told parameters. I think that's probably the safest way to do it. But everybody kind of has a different way of doing that. And then obviously any sort of if there's a hypertensive issue, then you can treat appropriately. I personally don't start them back up on their ARBs or their diuretics until a few days post-op. That's just my personal preference. Pulmonary. So I'm sure this has been harped upon, probably coming from us, but it's really, really important that they ambulate, cough, deep breathe. Pulmonary toileting is one of the most important things that, for these patients, right? So, obviously ambulation is important because it prevents DVTs, which is obviously that can be very dangerous. And especially if it's a lung cancer patient, right? They're going to be at risk, both from the surgery standpoint, from the malignancy standpoint, and then from the not getting up and walking around standpoint. So you put the SCVs, do the psychiatric, but it is really important to be ambulate. The other benefit of ambulation is that it can really help with pulmonary toileting. Where I came from, we actually didn't use incentive spirometers. Our hospital got rid of incentive spirometers entirely, and we did more lung surgery than I'd say 99% of the hospitals in the country, and that was not a problem. And all it took was just we got our patients, we had them walk in 5 times a day, and we were able to completely get rid of incentive spirometers. I think if you have them, great, and I think I would definitely use them. The one thing about the incentive spirometer is that you can really objectively track, right? You say, oh, you're inspiring 1,500 today. It's great. Why don't we aim for 2,000? So you give the patient something to track, but I think ambulation is probably the most important thing. So where I came from, it was 5 times a day, but I think if we shoot for 4, that's great. We can get patients up and walking around. And I know it's hard sometimes with staffing. But coughing, deep breathing, those are the other sorts of things. Sometimes we'll put patients on nebulizers to help open up the airways a little bit, loosen the secretions, and help them cough out some more junk. But that is really important, both from a DVT prevention standpoint and also from a respiratory failure / pneumonia standpoint, right? Because when patients are splinting, they're in pain, mucus builds up, they're not coughing it up, and then they get pneumonia, and then that's what sets them back pretty significantly. GI, I usually do clear as advanced as tolerated. If they're on a PPI, I'll restart that on them. GU, I just kind of keep an eye on the urine output. FEN, I'll usually, for these patients, you want to be cautious with fluids because when you take out part of the lung, they're at higher risk of going into pulmonary overload or fluid overload. They're at risk of going into AFib. So we try to not go too crazy with fluids. So I usually do, for the lung resections, I usually do 75 cc's an hour until they're taking in PO. And then once they're taking a good PO, you get rid of the fluids. And then sometimes, even with that, you still need to get the Lasix on post-op day 1, day 2, depending upon how things look. Endocrine, obviously, if if they're diabetic, resume some of those meds the day after, or sliding scale. And then I do sulfur-heparin, squeezy boots, getting up, walking around, TEDs. And then infection, usually they shouldn't have any need for antibiotics post-op unless they're managing an empyema, for instance, and that's any questions so far? Okay. All right, chest tube. So I think this is really, really important. Basically any patient who I go into the pleural space, I'm going to put a tube in. Okay. Have you guys seen this picture, this idea, this concept of the 3-chamber system? Anything else? Okay. So this is the old, this is how they managed entering the chest. Because for a very long time, people didn't really know how to operate in the chest because patients would die anytime they went to the chest. So they figured out that after the operation, you needed to suck air out, otherwise the lung would collapse, right? Like we talked about earlier. You need some way to suck the air out and not let air go back in. And then you also need some way to collect fluid that's draining, right? Because you have a bunch of blood that's collecting a bunch of fluid that's accumulating, and that's not good. So this is the 3-chamber system. This is conceptually what the Pleur-evac is. So basically, if you have a tube in the chest, and this is the pleural space, and you have a little bit of fluid, maybe you have some air leaking from the lung. So any air, any fluid will drain from the patient through the chest tube and into the first chamber. This is the drainage collection model, right? So fluid will collect here, right? So it'll settle here. Any air will then go into the next chamber, okay? And that's the underwater seal. And so basically what happens is air will go out, it'll bubble through this into the water, and then air will go out of the water, and it can't go back in. There's no way for the air to go back underwater, right? So that helps prevent air from going back in and creating and causing the lung to collapse, okay? And then the third chamber is the suction pressure regulator. I personally don't understand this perfectly, but the general principle behind this is this level between where the bottom of this is and the level of water, that regulates the actual amount of pressure that the patient feels when you put them on suction. Okay, and the older Pleur-evac, you'd actually see bubbling from this chamber. The newer ones, like for instance, ones that we have here, we call it dry system. So you don't actually see that bubbling anymore. But in the old, any of you guys remember the old ones that would bubble? Yeah, okay, good. All right. So yeah, so you would see it bubbling. That was a normal thing. And that's how it was. The newer ones don't have that. So this is the this is the what we have currently. I think this is the one that you guys all use here, right? So this is literally the Plur evac. And so this is basically this thing, but in the box form. Somebody just made this much more compact. And so this is the drainage tubing. Can you guys see? Sorry. This is the drainage tube. So this gets hooked up to the chest tube. This goes directly into the Plur vac, and then fluid will accumulate in these chambers. And you can measure the fluid amount and see how much is draining. Any air will then go up into this chamber. This is the water seal chamber. And so there's usually there's fluid in there, and there's usually a little white ball that rests on top of the fluid. Okay. And so any air that leaves the patient and goes through will go and push this little ball down, and you'll see the ball and the fluid will drop, and then you'll see a little bubble. And that's what we call an air leak. Okay. So if you have them cough and you don't see that ball drop all the way down and the fluid level drop all the way down and a little actual clear bubble of air go through, that's not actually a leak. A lot of times patients will have we call titling or pretty aggressive titling. So remember, this is all in connection to the pleural space. And so as the patient breathes, it changes the pressure. You may see that thing swing like crazy and it may create a ripple. And so it's very important, when I'm evaluating these, I always want to make sure that I truly see an air leak. In other words, air, the ball and the fluid drop all the way down. I see a little bubble of air come around this corner and out. And if I don't see that, then a lot of times it's what we call a ripple. Because especially if the fluid level's up here and you think you see something, you think you see a bubble here, a lot of times it's not actually an air leak. Does that make sense? Okay. And then who has a big tidal swing or ripple? It usually has to do with how much space is left. So in case patients have more space, usually there's more of that change in pressure, and you'll see that. And then this thing up here, that sets the pressure. So you hook up the suction somewhere. There's I think one of the things over there. There's a little nozzle where you hook up the suction, and you can crank the suction up, as high as you want. It doesn't matter because this will regulate the pressure. So you can actually turn this dial and change it from -20 of water, again that pressure level, -10, -40, 15. And then when you do that, there's a little orange indicator that will pop out once it's actually on suction. So if you don't see this orange thing pop out once it's on suction, this isn't actually on suction. And it's actually very dangerous if you have it hooked up to the suction and you don't see that, because now it's a closed system, right? There's no way, you're not sucking the air out, and you're hoping that the air can find a way, out of this system and into the wall suction that's turned off. So that's actually a very dangerous situation because you essentially it's like clamping the tube essentially. Follow me? Okay. All right. So there's a lot of different types of tubes. So you can have straight tubes, either straight hard tubes. I think these are the majority of tubes that we have here. So these are a bunch of different brand names. Some of these, Argyle, or is classically what we call them. And you can see there's a little white stripe there. That little white stripe is radio opaque, so you can actually see it on the X-ray, and that's how we know where this tube is. And then there's holes along the side of them. And so usually you can, the last hole is where that is on that radio opaque line. So when you see that gap in the radio opaque line, that's where the last hole is. Okay. So if you see that outside the pleural space, the tube is probably on its way out. So you should know about that. This is called the blade train. It's around you. I'm sure you guys have seen these before. I don't think we have any. Where I came from, a lot of times we place a 24 blade drain. I don't think we have them, but that's another drain that we may, in some cases place. And then some more specialty type drains. This one here is a pigtail kit. So see the little curve, that's why we call it a pigtail. And this is a tube that's either placed by us, interventional radiology, sometimes pulmonary will place these. These are typically 14 French in size. They're good for simple fluid. They're good for a pneumothorax that you just want to quickly drain. So that is something you will sometimes see. This is a tunneled catheter, pleural catheter. There's two brands that we use. Pleurex is one of them. I don't know if you guys have seen those. The other one, I don't know if they use this here, but it's called the Aspira catheter. But it's basically the same thing. Basically, this part of the tube goes into the pleural space with the holes. there's a little polyester cuff that sits within the soft tissue. We tunnel this in through the soft tissue, and this sits in the soft tissue just below the incision. Usually where this is going to the skin will be somewhere there. And this part's all external. And so that this is for patients who have pleural effusions that are going to be recurrent. We know they're going to come back. So typically patients with bad malignant effusions, whom no matter what we do, we're not going to be able to get that fluid to stop being created. This is something where they can go home with it. They can do it on their own. That's typically what that looks like. I may have some more pictures later. This thing I actually never used this until I came here. This one's called the Thoravent. You guys may have seen it. Typically placed by the ER. It's good for that spontaneous pneumo patient, and they just kind of jam this thing, usually second intercostal space, mid-clavicular line, and it's just a tube in the chest to drain the air, and then you can hook these up to suction. Yeah, you can hook these tubes up to suction. And then, so we'll usually, if we're going to hook up to suction, we put it to a Pleurovac. So there's an adapter. So those are just my general takes on how I manage chest tubes. So whenever I'm evaluating a patient in the morning, I always want to see from the tube going in sight all the way down to the Pleurovac and to the wall, and to whether it's suction. So I want to make sure the tube's not kinked at all. So I really just, I'll have, I don't say take the dress now, but I'll have them, lift their gown up. I take a look, make sure, follow it through. Sometimes they're lying in it, sometimes it's kinked and they don't even realize it. So I always make sure it's not kinked all the way through. And also that it's not coming out. That's the other thing. I always want to keep an eye on the output and quality, as well as the presence or absence of any air leak. We talked about that already. If you have somebody who's been fine, and all of a sudden they've got this like roaring air leak, especially if it's on suction, it may actually not be from the lung itself. It may actually be the tube is just disconnected somewhere, and you're just sucking in atmospheric air, through the Pleurovac. So that's something that's why I always check. Okay. The suction port and the suction tubing should really never be clamped or sealed off ever. There are specific times where we will clamp the chest tube itself. So those are, if you're going to change the Pleurovac, it makes sense to clamp it because you don't want, as you're changing it, as you disconnect, atmospheric air rushing into the patient. So we will clamp it for that. You hook it back up, you unclamp it. Okay. Sometimes I will clamp the tube if I think that I don't think they have an air leak, and or I don't think that they're going to reaccumulate a lot of fluid, but I'm not 100% sure. Before I take the tube out, I want to do a test trial of clamping the tube. I'll sometimes clamp it for that purpose. And so I'll usually clamp it for 4 hours, repeat an X-ray. If it looks good, I may take it out. I may, keep it clamped until the following day. I would obviously let you guys know that if I'm doing that, because not know why a tube is clamped. And then obviously if there's any issues, you just, if the patient's getting short of breath, issues, unclamp it and because you're always worried about a pneumothorax reaccumulating when you clamp the tube. But it's pretty rare that we actually clamp the tube. And then we talked about the suction being higher than the desired suction on the back. Make sense? Any questions? Okay, we talked about, so once the tube comes out of the body, what do you hook it up to? So again, you hook it up to a Pleurovac. Sometimes we'll use, if it's a mediastinal drain, I'm not worried about a pneumothorax or air leaking from the lung. We can sometimes hook it up to a bulb. So that's usually for the Blake drains. I'll do that. Sometimes patients are really sick. They've got an air leak and they're sick of being in the hospital. They've got too much output to go home, and they can tolerate being off of suction, but they still have an air leak, and I don't want to take the tube out because it's not safe. We got to find a way to send them home. So there's a few different options. So these are just two of them. One is something called the mini atriums. It's basically this Pleurovac in a smaller system. Do we have mini atriums here? Okay. Well, that's an option for patients who are stuck in the hospital and they still have an air leak, but they can tolerate it on water seal. One thing I didn't mention, so water seal versus suction, right? So you can put it to suction where you're actively sucking stuff out. You see that orange bellow. You can also just put it to water seal where you just rely on that water chamber to prevent air from going back in. So any air that they accumulate in the pleural space can passively drain, and you just let it passively drain. And that's what we call water seal. And we'll typically do that before we take the tube out because it proves to us that if there's no air leak on water seal, then we're usually pretty good to take the tube out. So that's the mini atrium. And the third thing is something called a Heimlich valve. basically it's just a one-way valve that allows fluid and air to drain from the patient, but won't let air go back in. Basically, as they inspire, there's negative pressure. So the valve, it's basically just like rubber, thin rubber, and it just kind of closes on itself. And then when they breathe out, there's positive pressure and it blows open so that fluid or the air can drain out there into the air. Okay. It's really important not to place these on reverse. So that's super important because then you've created a one-way valve the wrong way. And then these are just some of the drainage systems for the various tunnel catheters. I talked about the Pleurex and the Aspira. This is the Pleurex one. So basically, you'll see the little tubing coming out. You hook this part of the tubing, actually this part of the tubing into the Pleurex, the tip of the Pleurex. It's usually a cap. You take the cap off, clean with alcohol, plug these in, twist, and then this drainage bottle. There's a little flat part there. You push that in, and that opens the suction. This bottle has got negative pressure already set in it, and it just sucks the fluid out. There's usually a roller clamp that you can kind of control the amount of drainage, and patients will let you know when to stop draining. Either it stops draining on its own, or they start having pain, discomfort. That's usually when they stop draining. And then typically the Pleurex itself is looped around a foam gauze, and then you put around. It's basically a drain sponge that goes around the tube. You wrap the tube around that, and on top, put another gauze on top of that, and a tegaderm over that. So basically, you're just trying to prevent the tube from being in contact with the skin and causing erosion of the skin. And this is the one for the Aspira. This little, I had actually first time using it on Monday. This basically is a drainage bag, and you hook that up to the Aspira catheter. And there's a little hand pump that you pump, and you need the hand pump where you kind of just drop the bag on the floor, and it'll help suck out. I guess there's also a bottle system that's pretty similar to the Pleurex. Have you guys used these before on the floor? Yeah. Okay. All right, 15 more minutes. Okay. Post-operative care. So, when I'm looking at patients, I want to know, any big 24-hour events, what are the vitals, what O2 requirements, if there are any drips, with IV fluids, their eyes and nose. Eyes and nose are actually, I think, unsung hero of post-operative care. It's really helpful if I know, what's their fluid balance? Are they like 3 liters positive? Do they need Lasix today? That's very helpful for me when I'm trying to make decisions about how to manage these patients. So I think, strict eyes and nose can be very, very helpful. And it's tough if they're, waiting in a bed, in the urinal or bedpan or whatever, but if we can get those numbers, it can be helpful. And then I also wonder about the chest tube output. Obviously I look at the wounds, I look at the chest tube, and we talked about that. And then I want to look at if there's an air leak and then what's the quality of the fluid. Okay. What are we trying to avoid? We're trying to avoid complications, right? That's when we're rounding, that's really what we're looking for. What problems did I cause by operating on this person? That's what I'm force my mind. So respiratory. So the biggest things are probably gonna be atelectasis, so they're not taking a nice big deep breaths in because they're splinting, coughing, deep breathing. Prolonged air leaks. So sometimes, if the lung, especially if the lung is really bad, it takes a while for that lung to seal up. So you have this prolonged air leak, and we define prolonged air leak as anything more than 5 days of air leak. And it sometimes happens, especially in really bad COPD patients. Honestly, as I've started doing more segmentectomies, where I'm having to cut through more of the lung parenchyma rather than relying on the natural fissures of the lungs, we see a bit more of this because you're cutting through a denser or larger quantity of lung, and so a little bit more air leak. Pulmonary edema, right? We talk about the patients can go into fluid overload. ARDS, that's pretty rare, thankfully, knock on wood, that we have patients go into ARDS, but it can certainly happen. Cardiac, so we're really worried about heart attacks. AFib is very common. Usually it's post-op day 2, day 3 when patients steal their capillary leak. So the inflammatory response has gone down. All that extra fluid that you gave them, that was in the soft tissue is now kind of rushing back into the venous system, and then that's when the heart sees that extra fluid and that strain, and that's when they go into AFib. So, I know we're kind of like, it's post-op day 2, they're doing great. That's post-op day 2 is where let's, really keep an eye on them because that's when they're going to go into AFib. Bleeding, thankfully pretty rare. Infection, again, the most common infection for us is going to be a pneumonia. Very, very, very rare that we see a wound infection. I think I've seen it once maybe in the last 5 years. And then chylothorax. Does anybody know what chylothorax is? You guys heard of that? Bonus points? Okay, chylothorax. So it's chyle fluid. So chyle fluid is lymphatic fluid. Okay, so when we're doing these operations in the lungs, it's pretty rare, but especially if we're more aggressive with our lymph node dissection, where we take out lymph nodes when we do these operations as well, the lymphatic channels can be disrupted. So you can have lymphatic fluid leaking into the chest. Many times, especially for lung resection, is not a big deal, and it will stop at its own. So the lymphatic fluid in the chest, actually, a lot of it comes from the belly. Okay, so as we eat a fatty meal, right, some of those triglycerides are absorbed directly into the bloodstream via the intestinal lacteals. Some of them are absorbed through, they turn into something called chylomicrons. Have you guys heard of these? No? Okay, chylomicrons. So basically, that's one way that we process different triglycerides. So the fats turn into, the body converts them into chylomicrons. They get absorbed in something called the cisterna-chyli, which are these little channels within the abdomen. They all kind of fuse together, and they form something called the thoracic duct, which is this thin little tube that runs along the chest, and then it usually runs along on the right side, and it kind of crosses over at about T4, and then it goes up, and then it kind of dumps into the innominate vein, subclavian vein junction, left side. There's a lot of variability for the thoracic duct. Some people have two of them. Some people have just purely left-sided. So there is some variability. Again, we're usually not messing with the thoracic duct when we're doing lung resection. When we see chylothorax, typically it's either after lung transplant or esophageal surgery. But you can see it with the lung resection, especially again with the aggressive lymph node dissection. The treatment for that is actually, you want to decrease the amount of fat taken because remember we talked about the fat that most of it comes from fat that you eat. So we change the diet either to, if it's really bad, we make an MPO. We put them on a medium chain triglyceride diet or very low fat diet or no fat diet. And that, depending upon the output, usually for a lung resection should solve the problem. There are other things you can do. You can put them on octreotide and decrease the amount of chylous fluid there, or you can even go back and either operate on them and ligate the thoracic duct or find where it's leaking from and ligate that, or have the interventional radiologist. They can sometimes access the lymphatic system and then little coils and embolize the leak. Very rare that we have to deal with that. What does it look like? So when you're looking at the chest tube, if all of a sudden it looks milky, okay, or fatty, that's concerning for a chylothorax. And so you let us know, and we'll send triglycerides off the fluid. Treatment is usually just making an MPO and those other things that we talked about. Okay. I think that's it. Yeah. Well, okay. We've got 10 more minutes. Any questions? I know I went through lots of, yeah.
What would cause like a crepitus? Because I feel like the only times I've had patients that have crepitus is when they have a chest tube.
Yeah. So crepitus is air outside of, crepitus is air that's within the soft tissue. Okay. So if you get a CAT scan and somebody who's got crepitus, you'll see kind of air kind of scattered throughout the soft tissue. And so what that's a sign of, there's a few different causes of that. So one is there air leaking from the lung itself that the chest tube isn't capturing and it's finding some other pathway because it's going to want to go somewhere. And so it goes into the chest tissue. And for whatever reason, maybe the lung is expanded to the point where it's blocking the holes in the chest tube, but there's still air leaking in a different spot. And that's the chest tube not capturing. And that's why you're seeing this crepitus. Sometimes it's related to the operation itself. So when we do these operations, a lot of times we put CO2 into the chest to help deflate the lung a little bit more, give us a little more room to work. And that's positive pressure. The machine is blasting CO2. And so if that port is not fully seated, or even if it is sometimes, we'll still see it. Some of that CO2 makes its way into the soft tissue. And so you'll see that crepitus. It feels like, everybody has felt crepitus. Feels like kind of like Rice Krispies, is how I describe it. Or the way I describe it is almost like, in the winter when you step on, snowy ice, it kind of has a crunchy kind of feel to it. That's sort of what it feels like to me. The important things are, one, it's not dangerous. Crepitus in and of itself is not dangerous. I've had patients, because it's a sign of subcutaneous emphysema. And I've had patients who got so much subcutaneous emphysema that they're so swollen, they're like the Michelin Man. You can't see out of their eyes, literally. Like they're so. I don't know. Have you guys anybody seen that before?
Yes.
Yeah. It's not dangerous because it's air, right? And air is compressible. So air is not gonna, when you think about like, oh, if you saw something like that after a thyroid surgery who's got that degree of swelling, you'd be freaking out because that's blood and that's gonna compress the airway and they're gonna coat on you. You're not gonna get a breathing tube in them. but this is air. It's not going to compress anything, so it's not dangerous. It's just annoying. It is a sign that if it's persistent, it is a sign that potentially there's still air leaking from the lungs. So maybe you should leave the chest tube in for longer. The strategy is to manage it so you can increase the suction on the chest tube to try to preferentially drain some of that air into the out through the chest tube. Sometimes we make what are called gill slits. So basically, you make a little incision in the soft tissue. You can either pack. Sometimes you can put a little packing strip in there. The other thing that works, I think, really well is you actually put a little black wound vac sponge in there and you suction on it, right? You put a little suction thing and that will help suction that air out. And honestly, like when I was a fellow, I would sometimes go around like twice a day, 3 times a day on some of these patients who were really blown up. You just kind of milk that subcutaneous emphysema towards that area and it would help. It would decrease some of the that air. But it's dependent upon 3 things. So one is if they're laying, if you push on it, you can push that air somewhere else. It'll go anywhere. So you do have to be careful when you're trying to figure out is this getting worse or not. Are they just in a different position? Has it moved? And sometimes you will see it. You will see it kind of move around. But it's not because of the chest tube. The chest tube may actually be helping drain and preventing a pneumothorax. Because again, I'm not worried about subcutaneous emphysema. I'm not worried about crepitus. I am worried about nearly. Now, that's for lung surgery. Now, if you told me that they were stabbed in the neck and they've got crepitus, then I get really worried, right? And that's a different scenario. But in general, if we think it's from the lung and we have a tube in place, I don't get too worked over. That's a good question. Any other questions?
Hi. As we were rounding with the chest tube on the med surg floors, everywhere that they take care of inpatients. I'm from education. We talked about what to do if the tube is kind of accidentally removed. And we talked about the purpose of the chest tube having be inserted in the first place and that we would manage it in 2 different ways, whether it was for a pneumo or for fluid removal. So as you were showing us the pictures from during thoracic surgery and explaining that the one lung is deflated during surgery, it kind of had me reflecting back. Is the purpose of the post-op chest tube purely for fluid removal, or is it twofold to also allow the air?
Yeah, it's both.
Yeah.
So certainly, we talked about the lung, leaking air, and so you have to drain the air. That is, you really need to. The pleural space has an ability to absorb a decent amount of fluid. So typically, we're okay taking these tubes out if it's less than 200. Honestly, there's some papers that are saying you can take the tubes out when the pleural fluid is 4. If I have somebody who is draining 250, 260. If a tube accidentally gets dislodged or disconnected, I would say if it gets disconnected, first thing, hook it back up, get an X-ray, okay? Notify the provider. If it gets dislodged, notify the provider. One thing you can do is you can place a 3-sided occlusive dressing. So basically, it's occlusive dressing, and one side is not excluded, so that when they breathe in, the negative pressure sucks the dressing down. When they breathe out, it allows it to release. I wouldn't necessarily rely on that. I think trauma and you have nothing else to do, but here in the hospital, I think probably the safest thing to do would be, so was there an air leak before the tube came out? If there wasn't, probably watch it and repeat an X-ray, get an X-ray and repeat it in a few hours. Obviously, if it's worse, they become hypotensive or whatever, then we may need to replace the tube. That's a pretty miserable situation. And, it's never going to happen here because you guys aren't going to let it happen. So it's not a problem. No, but it can happen certainly. And
Do you stitch?
Mhm.
You do-
yeah, we'll put for most of our tubes we'll have a drain stitch. So usually it's an O-silk suture that we stitch the soft tissue tie a little air knot, wrap it around the tube a bunch of times, tie really tight, maybe tie a few more times, tie really tight. And then we also have, a lot of times we'll also have a U-stitch. So basically that's a stitch that goes around the wound. When we pull the chest tube out, the other person ties that one down and that seals up the wound. So the reason I'm hesitant to say immediately just, seal up the wound. I mean, you can put a dressing on, that's fine. But if there's an air leak, I mean, if it happens and we'll deal with it and then you need a tube. I wouldn't blindly, I mean, I would, certainly I wouldn't go just immediately replacing that tube, sterility issue. Definitely chest X-ray, definitely notify the provider. And then if they're an extremis, they need it too quickly. If they're truly an extremis, then yeah, I mean, I think then just throw a bunch of betadine on the wound and then just put a tube in the same incision just to get something, put your finger in and take a deal. Hopefully you guys aren't going to be in that situation. Not you guys, maybe the ACP or whatever.
Yeah.
So just to follow up, so the information that we had was that if the indication for the tube being inserted was purely to drain fluid, then it should be Xeroform and Tegaderm.
Yeah, that's totally safe.
This is all while we wait for you, right? But we just want
No,
to
that,
provide
yeah,
proper guidance.
yeah. So if it's for fluid, then that's totally fine. If it's for air, it's a little bit trickier, right? Because I need to know if there's currently there was an active air leak. If there was an active air leak, yeah, I mean, you can leave it open. And if it's, if there's truly air building back up, then you may prevent a tension pneumo. You may also suck a bunch of air in and cause lung to collapse as well. But they shouldn't go into tension in theory, if that air, in theory, there's a way for it to evacuate. So that's reasonable. Active air leak, that, yeah. When you give it a shot, you cover it up and then see what happens, get an X-ray if you don't. Close eye on them. Anything else? Any other questions, guys? Thanks for your time and for taking care of our patients. I think we're doing another lecture thing, right?
Next month.
Next month? Okay.
27.
Bigger group, I guess.
Yeah.
Right. Well, yeah, you guys can find me, like my email is jyoung18, or Tiger Text or whatever. I guess everybody uses Tiger Text these days. You can Tiger Text me or whatever. You guys have questions. Happy to answer them. Thanks, guys.
Thank you.
20 years ago.
Yeah.
I was here
gonna
when
ask.
they,
We've done it a couple of times.
Yeah. With cryo in.
Yeah.
I still want to eat, right?
Report.
Oh, God. Yeah, okay.
If it's a formal conference, just one thing you can do is just take a sterile, disconnect to the sterile section catheter.
Yeah.
I've done that.